So hello and welcome back. I'll be discussing the second part on our approach to fibrotic ILDs under the general approach to chronic dyspnea. And today we'll be discussing imaging in fibrotic ILDs. And as I discussed in the previous discussion on this video, we'll be trying to derive a diagnostic framework for the same. This diagnostic framework will be based on imaging. That is why I've given it a separate discussion. I've kept it separate from the general understanding of how fibrotic ILDs arise. Okay, so we've already established in our previous discussion that the usual interstitial pneumonia pattern it results from the physical and biological constraints that are placed on type 2 pneumocytes. That was what we discussed last time, and this results in a clear apicobasal gradient, that is basal predominance, and it results in a clear subpleural dominance of the pathologies. Okay. Now, so what we're going to do is going to try to derive a diagnostic framework based on our understanding of the patterns of fibrotic ILD, and in this discussion, I'll try to demonstrate that clinical images showing reticular opacities. So we've already discussed the general approach to hyperintense lung opacities in this series previously. I'll link that video in the description. And continuing from that, when you have a reticular opacity, in any clinical HRCT or even a chest X-ray, these images can then be subclassified into four, for want of a better word, buckets. Okay, that comply with the rules that we just established for usual interstitial pneumonia. So these have actually been formalized by the Fleischner Society guidelines, and we'll be getting into that just now. And we'll then try to understand why histopathology is, although how the term usual interstitial pneumonia came to be, it is at the present moment only required in very specific scenarios. The third thing we'll try to do is deduce the entities that may mimic this fibrotic ILD pattern. Okay, and admittedly, we'll understand that any disease that has to, mimic this fibrotic ILD UIP pattern would have to do so by jumping through many proverbial hoops. Okay, so obviously in the clinical context, these entities must be suspected with some degree of caution. And finally, we'll try to derive as I've been promising for a while, the diagnostic framework for fibrotic ILDs based on these three primary principles. Okay, so the Fleischner Society guidelines divide fibrotic ILD HRCT images into these four buckets. Okay, they are typical for UIP, probable for UIP, indeterminate for UIP, and alternate diagnosis. Okay, and obviously these mean what they imply. So we'll try to see how these buckets fall into a spectrum. So alternate diagnosis is, obviously, now see, our basic premise is that when you take a lung and there is a reticular opacity in that lung, that reticular opacity, if it is usual interstitial pneumonia, pathophysiologically speaking, it should predominantly affect the base of the lung, and it should predominantly affect the subpleural areas of the lung. Okay, this should be the distribution, and we've discussed the reasons, the physical and biological reasons for the same in our previous discussion. So we'll see when a pathology does not comply with that, as in it is upper lobe predominant, or it is mid lung predominant, or it is predominantly central, as in the pathology is involving the hilar region or the peribronchovascular region rather than involving the subpleural region. In that situation, it is not UIP. Okay, because UIP has to follow that pattern. Okay, now the other things that would be odd in UIP is, I told you that, see, in UIP there is fibrosis and then there is alveolar fusion, and that alveolar fusion results in the formation of a very specific distribution of cysts. Okay, that is what we histologically and then clinically also refer to as as a honeycombing. Okay, so the presence of alternate findings doesn't fit into our model of UIP-ILD. Okay, the pathophysiological model. So it is not really good to consider. So N stands for nodules, not really compatible with UIP. Although see, that nodule is not compatible with ILD. If the rest of the pattern is that of UIP-ILD, then it is UIP-ILD with a nodule. Okay, but a nodule in isolation is not UIP. Then GGOs, ground glass opacities, okay, consolidations, cysts, and finally expiratory air trapping, what is called mosaic attenuation. Now please notice the term expiratory here. That is, it has to be an expiratory HRCT. So most HRCTs are taken during the peak of inspiration. A patient is asked to hold their breath and then a helical CT acquisition is done. Okay, so this has to be done in the reverse. The patient has to be asked to breathe out and then hold their breath. Okay, so this is something that is slightly different, and then you have to actually ask for an expiratory CT. Okay, but only in an expiratory CT can you then call it mosaic attenuation. We've gone into this in that discussion as that I had referred to just prior. Okay, now typical for UIP, probable UIP, and indeterminate for UIP, all three show reticular opacities in a craniocaudal gradient. As in, if you take the lung, the pathology primarily affects the base of the lung. Okay, and they show a subpleural dominant lesion. So this will be the distribution. Okay, so what I've shaded in blue, this will be the distribution of the pathology. Okay, so however, that in itself is not sufficient. You need certain other criteria to be fulfilled for you to be sure that this is definitely UIP and nothing else. Because as we discussed, NSIP can recapitulate part of it. It can show basal predominance because NSIP is due to local innate immune activation, that is interferon type 1 interferon production, and causing secondary fibroblast activation and fibrosis, and that would follow the gradient of blood flow into the lungs, and there is 16 times greater blood flow to the base of the lung as compared to the apex of the lung. So that leaves us with a slight overlap. Okay, so how do we clinically reconcile ourselves to this overlap, and how do we avoid getting confused in most situations? Okay, so one is you look for honeycombing, because as I've just discussed, honeycombing and or subpleural and basal predominant tractional bronchiectasis are very characteristic of typical UIP, and therefore they would put the patient in that bucket. Okay. On the other hand, just tractional bronchiectasis, again, tractional bronchiectasis implies there is myofibroblast formation within those fibrotic foci, and that is something that is very characteristic of the extent of fibrosis that is happening in UIP-ILD. We've gotten into the pathogenesis of this in the last discussion. So it is quite suggestive of UIP, but it is not definite for UIP. So we would still call it probable UIP. Okay. Now let's just go through some images that demonstrate these 3 buckets of patients or 4 buckets of patients. So one is this is the first HRCT that we'll see. So here you can see this is a coronal acquisition. The gating has been done in order to show you the parenchyma properly. Okay, that is not the gating, the windowing. Sorry, I get the terminology from flow cytometry is getting coming here. So anyway, a coronal acquisition has been done, and a coronal image has been shown to you, and this is obviously windowing has been done such that parenchymal structures are clearly differentiated from one another. So what we find is you can see your right lung and your left lung. Okay, and what we find is there are some reticular opacities. There are lace-like opacities here. Okay, and what you can definitely say is that the apices seem to be spared, whereas the bases are affected. Okay, and there is some subpleural involved. So this is the distribution of our pathology, and this is obviously very, very compatible with what you would expect with a UIP type pathophysiology. Now, again, on axial cuts through the same lung, you find again that the higher you are in the lung, that is, obviously this is before the splitting of the trachea or proximal to that. So here you find there is very minimal lung fibrosis. As you go down, these are progressively more caudal cuts. You find more and more fibrosis. Okay, but again, the fibrosis is showing a predominantly subpleural and basal distribution. Okay, so it's increasing in this direction, and it is always subpleural. Okay, the absence or the even, it's like religious dogma. The just the fact that a pathology can, go in or counter this basic principle of UIP makes it unlikely or less likely that it is UIP. So that's how characteristic it is of UIP. Finally, you can see that I'm calling it typical for UIP because of two very important things that you find here. Okay, there is there is honeycombing. So this is honeycombing here. That means there are small cysts present in layers of 1 to 3 up to 10, okay, present in the subpleural regions. And you find that there is some ground glassing, and we've discussed this previously. The ground glassing can represent fibrosis that was too fine for the limits of resolution of your CT image acquisition to resolve. So that would also result in a ground glass opacity. It's just the limit of the imaging modality that you're doing. Okay. So along with that, what you find is there is a little bit of tractional bronchiectasis. Okay. So there are some dilated bronchi within it. And this is therefore typical. See this bronchus here. So this is typical for UIP. This is typical for UIP. Okay. Now going on to the next one, that is probable for UIP. Again, you do see a craniocaudal gradient. You can see that the apices are relatively spared. Okay, especially on the left side, there is subpleural involvement more on the base. Again, subpleural involvement more on the base. Even on the right side, if you look carefully, there is subpleural involvement more on the base. Okay, but there is no honeycombing, unlike the previous case. And when you take axial cuts, you do find that as you go from, this is above the level of the carina. So this is a higher cut, and this is the lowest cut, right, at almost at the diaphragmatic or at the diaphragmatic level. As you go from here to here, you find that the number of reticular opacities is definitely increasing. The volume or the area affected is getting increasing, and the opacities seem to be obeying the basic tenets of a UIP pattern, that is, they are subpleural. Okay, and again here also they are predominantly subpleural. Even in the highest cuts, the very minimal fibrosis that we have, that is in the subpleural distribution. Okay, so there is a definite apicobasal gradient. Now finally, however, you do not find what we really need to qualify this as definite or typical for UIP. That is, we do not find honeycombing. Okay, so there is no honeycombing, so it does not classify as typical UIP. It is probable UIP. Now when it comes to indeterminate for UIP, we find things that are not heretic. It's not heresy, but those that would put the image under the category of alternative diagnosis, but it still goes in the face of what you would expect with UIP. Okay, so that would be a prominent peribronchovascular pattern. Now, admittedly, you would say, okay, so why is this not alternate diagnosis? Now, why it is not alternate diagnosis is because the weight of evidence still is pulling towards UIP, because there is apical sparing. Okay, there is basal predominance, and to some extent there is subpleural involvement. Definitely no subpleural sparing per se. Okay, so there is peribronchovascular thickening, yes, but in addition to that, there is also subpleural involvement. So it's like it's a very religious person who has got one flaw. So in that situation, we can't really say that that one flaw is a completely, it makes completely counters the fact that they are religious. Okay, so this is why it is indeterminate for UIP. Okay, now here there is again no clear apicocranial gradient, although I would argue there is some. Okay, definitely these images show a little bit of more fibrosis than the others, but that is again my subjective opinion. Again, when it becomes subjective, put it in indeterminate for UIP. Okay, then finally, you can see that this prominent peribronchial vascular involvement is very unusual for UIP. It's not incompatible with UIP as long as there is no subpleural sparing, okay, which is not there. Subpleural involvement is there, okay, but it is still very odd. You would need an alternate explanation to explain why UIP pattern is involving the peribronchovascular regions. It's probably another pathology along with UIP. Okay, now histologically speaking, see, UIP and NSIP, the terms arose from histology. They did not arise from imaging or from clinical medicine. So when you look at biopsy specimens from these people, what you find is in UIP you have foci of fibrosis, that is fibroblastic foci, and we've discussed why that happens. Okay, so the type 2 pneumocyte, as it is forced to proliferate in order to cover up for the lack of the type 1 pneumocyte, it produces extracellular matrix degrading proteins, which then liberate, so to say, TGF beta and FGF2, as a result, resulting in the local fibroblasts getting a stimulus for proliferation. And we also discussed that in some cases, probably not all, there is also a Th2 polarized immune response that plays a role, and that naturally produces IL-4, 5, and 13, and IL-4 and 13 then also induce this kind of fibroblast proliferation. So we've discussed that how this comes to be, but what would that look like under the microscope? So under the microscope, what you find is, you find what you would expect. That is, you find these foci of proliferating fibroblasts. Okay, and just next to those proliferating fibroblasts, you see these intensely eosinophilic bands. Okay, these are collagen bands of collagen that have been deposited by those proliferating fibroblasts. Okay, and there is also a very interesting thing that as the fibroblasts proliferate, they produce mucopolysaccharides, and that gives it a slightly basophilic color, and that is something that is histologically characteristic, but otherwise you wouldn't see it obviously on imaging. Okay. Now on the other hand, in NSIP you can see that unlike the UIP pattern that I've shown on the left side, in NSIP the alveoli seem to be completely or at least partially spared. There's just a little bit of thickening of the septa of the interalveolar septal space. Okay, you can almost actually trace out the alveoli. It's just that the septa are, so this would be a normal septa here. Okay, see how thin it is, whereas this would be a normal septa. Okay, whereas this just adjacent to that, we've got a very thick septum here. See, so there's like a thick lymphocytic infiltrate into the septum, and some of it is showing a little bit of fibrosis, but this would predominantly be a cellular NSIP. Okay, now, so when do I need to take a lung biopsy? That brings us to the question. So obviously, the obvious answer from what we've understood till now is when you have an indeterminate for UIP pattern. Okay, because an indeterminate for UIP pattern implies that there is something else happening. Okay, so now there is a situation in which we also do it for UIP and IPF patterns. Okay, that is when, okay, actually there is no situation in which you do it. You do it when okay, so I wanted to highlight something else. So basically what I'm trying to get at is, see, when we talk about imaging, in imaging the distribution is very, very important, and we give a lot of credence to honeycombing, whereas in histopath what we look for is not actually honeycombing. Okay, it is the presence of subpleural and paraseptal. involvement. Again, the principle is the same, but obviously the resolution of our histopathological analysis is much more than that of clinical imaging. So that is when it requires. So see, if you have an indeterminate for UIP, basically what that clinically implies is if you have an indeterminate for UIP pattern and you do a lung biopsy, and in that there is subpleural and or paraseptal distribution of fibroblastic foci with adjacent fibrosis, and there is patchy lung involvement with areas of sparing and with areas of significant involvement, but there is no honeycombing, it still would put the patient in the bucket of UIP or IPF pattern by histology. Because in histology honeycombing is not given as much of importance. It is the subpleural paraseptal distribution that is more important. Okay. Now the thing is, there are cases where you have probable UIP, where you go for a biopsy. And this is because you want to negate giving treatment to the patient. For example, I get a patient with say RAILD, and the patient has got probable UIP pattern. But it has just started, and over the next few months the patient's clinical condition worsens, the shortness of breath is worsening, the oxygen the patient starts having oxygen requirement. So in that situation, I want to see whether this is likely going to be amenable to immunosuppression. So one way I could go about it is to give a trial, but obviously it is reasonable to consider doing a biopsy. So in that biopsy, however, if I get only honeycomb fibrosis, now please understand, it is probable for UIP. So the pretest probability prior to this histo was higher than in our previous case, and what I got was honeycombing, which on imaging I consider to be definite or very typical for UIP. That on imaging, however, is still going on histopath is still going to put the patient under the in the bucket of probable for UIP. So basically the buckets, although they have the same name, at least probable UIP pattern is the common name of bucket in both situations. The content is slightly different when it is an HRT-CT image that is being analyzed versus what the biopsy is being analyzed. So now the thing is, there is one entity that is hypersensitive to pneumonitis that can closely mimic usual interstitial pneumonia. But again, it has to jump through multiple hoops. So it has to jump through these hoops, and then only then can it mimic UIP. Now, so we need to see whether or not it has jumped through those hoops. So the approach to a suspicion of HP in a case of fibrotic ILD is heavily dependent on the presence of a radiographic entity called small airway disease. So say you are clinically suspicious that there is a likelihood of hypersensitive to pneumonitis. Why? Because there is some exposure. The patient's job indicates that they may have had exposure, or it is probable UIP or indeterminate for UIP. And or there is either probable UIP or indeterminate for UIP. In that situation, what we do is we look for evidence of quote unquote small airway disease. So what is small airway disease? It is the presence of any one of three findings on imaging. One is ill-defined centrilobular nodular interstitial pattern. Now per se, the presence of a few nodules would put the patient in alternate diagnosis category, in the alternate diagnosis bucket. But the presence of ill-defined centrilobular nodules doesn't necessarily negate UIP completely, because that's a very non-specific finding. The second thing is the three density sign, what was earlier called the head cheese sign. The three density sign is a combination of three things. It is the presence of air trapping, ground glass opacities, and normal lung. And this is in the almost as if they are put together in the form of a jigsaw puzzle. So the one area will have ground glass opacities, one area will show air trapping, and one area will be relatively normal. So now importantly, air trapping, when I say air trapping, that means what? It has to be trapped during expiration. So it has to be an expiratory HRCT. On the other hand, just the presence of air trapping is also highly suggestive. Okay, so see, now you can get a triple density sign even in a normal inspiratory HRCT, but that would imply much more advanced disease. And in that situation, air trapping is occurring, is persisting even when the patient is having, not in full, it's not during expiration. Okay. Now, when you have suspicion of HP in a particular case of fibrotic ILD, you first see, is there any evidence of any of those three things? Okay, any evidence of small airway disease? If yes, you look for the distribution. Okay, now if it is either mid lung zone predominant, okay, or it is showing a relative sparing of the base, which is inverse of what would happen with UIP, or there is a random distribution, randomly, the apex, the cranium, the apex is affected, then the base is affected, okay, or the axial, there's some very prominent axial involvement. So probably it would be in a probable for UIP pattern from that perspective. In that situation, we say it is typical HP. So typical HP is a non-UIP distribution plus small airway disease. Okay. Whereas if you have small airway disease, but you have a UIP distribution, the patient then gets put in compatible with HP. So you could have patients who have a probable for UIP from the perspective of trying to ascertain whether it is UIP or not, and be compatible with HP. Okay, these are the patients who are probable for UIP who would probably require a biopsy. Okay, now on the other hand, you could have no small airway disease. Now, when you don't have small airway disease, see, small airway disease is pathognomic of HP, hypersensitivity pneumonitis, but it is not universally present in hypersensitivity pneumonitis. So it could then you to give the patient's image the moniker of indeterminate for UIP. Okay, sorry, indeterminate for HP. Okay. Now, this may include a variety of entities. It could include probable UIP. It could include the indeterminate for UIP pattern. It could include fibrotic NSIP. It could also there could be a true indeterminate pattern, which is something that obviously requires you to have seen clinical images. So I'll avoid that confusion for now. Make the base very clear, and then we can go into the nuanced data. Okay. So as long as there is concomitant small airway disease, probable HP can have two variant distributions. It could be showing this kind of UIP-like distribution. That is, it could be having a even subpleural involvement, basal. Okay, this is not basal predominant, mid-lung predominant, but definitely subpleural, and there appears to be some honeycombing. Okay, so this could be upper lobe predominant, or it could show this kind of central involvement. Okay, so these are the two things that might happen. Okay, so when you have these two images, you're pretty sure it's not UIP. Okay, and then there is small airway disease, so it's definite HP. Okay, typical for HP. So in this entire algorithm, when you are suspecting HP and you think it is compatible with HP, this would include what all? This would include any UIP pattern that is probable for UIP, or even or not typical for UIP, but okay, probable for UIP pattern usually, which has small airway disease. Okay, so essentially what I'm trying to say is small airway disease equals HP. Okay, and gets more credence than a non-UIP distribution. And in case of UIP, what is most important is distribution, yes, but also honeycombing on imaging, and on biopsy, the paraseptal or subpleural distribution with patchy involvement. Okay. Now, yeah, so these are the two variant morphologies that you might get in a patient with HP. That is, you can get typical for UIP patterns, but see, typical for UIP, but small airway disease is present. So still, it could be HP, and in that situation, you'd probably require a biopsy even then. Okay, and this is your prominent ground glass opacities, and this would obviously cause confusion with NSIP pattern, which will come to. NSIP often has the prominent GGOs. Okay, we've discussed this previously in our discussion on data. So now I've come to demonstrate, I have been able to demonstrate to you that clinical images showing reticular opacities form a range based on how well they comply with the central dogma of UIP. Okay, that is formalized in the Fleischner Society guidelines. That is, UIP pattern ILD affects the base of the lung and it affects subpleural areas. Okay, it's literally dogma. Now, we've also understood why histopathology is required in some very specific scenarios. And what were those scenarios? That was when you had a probable UIP or indeterminate for UIP pattern, okay, and you had a you were planning immunosuppression, or you were planning something drastic, or you had any typical for UIP, or but even typical for UIP, probable UIP, or indeterminate for UIP, and you had small airway disease. Okay, in that situation, if it was small airway disease plus typical for UIP or probable UIP, I would still go in for a biopsy. Okay, or do serology for HP, but that determines, the causes of HP vary from patient to patient, and what exposures the patient has gotten, and you may not have the appropriate serology. Okay. Okay. Finally, we've been able to deduce the entities that mimic the fibrotic ILD pattern, and as I have shown you, HP has to jump through a lot of hoops in order to recapitulate that pattern. Okay. Now, finally, I'm going to derive a generalizable diagnostic framework for fibrotic ILD based on these three primary guiding principles. Okay. So the first step in this algorithm is to determine apicobasal gradient. Okay. So you could have three possible outcomes. One is that there is apical predominance. Second is that there is basal predominance. Okay. Third is that there is no significant predominance. So if there is apical predominance, then I can essentially rule out UIP, and I can rule out fibrotic NSIP. Again, the base of the lung, 16 times blood flow as compared to the apex. So NSIP is far more common in the base. So when you have a pathology that is affecting only the lung apices, then the diagnosis is a very short differential diagnosis, and we'll just come to that shortly. Okay. Now, on the other hand, if it is basal, you can actually rule out the short differential diagnosis, and again UIP and fibrotic NSIP become become the likely diagnosis. If it is neither, then actually we can't really say anything, we can't rule out anything. Okay, so what is this short differential diagnosis? S stands for sarcoidosis. Okay, H stands for hypersensitivity pneumonitis, typically acute or at least subacute. O stands for occupation lung disease. This excludes asbestosis, as we discussed in our previous discussion in this series. R stands for radiation pneumonitis, obviously occurs in a very specific clinical scenario. And T stands for tuberculosis, would usually show a significant unilateral predominance. And DDX stands for double damage or pleuroparenchymal fibroelastosis, which although in most literature it is idiopathic, it occurs with systemic sclerosis. So from the context of internal medicine and rheumatology, that is where it becomes relevant. Now, in the second step, we determine the axial distribution of the fibrosis. So three possibilities arise. There is subpleural, complete subpleural sparing. There is predominant central and peribronchovascular involvement. Okay, or there is both. Okay. Now, if there is sparing of subpleural parenchyma, you can rule out UIP. Okay, because UIP must involve the subpleural area. Okay. Again, if you have predominant central or perivascular involvement, again you can rule out UIP. Okay. On the other hand, the differentials still remain quite extensive. Okay, they still remain fibrotic NSIP, yes, because fibrotic NSIP only shows basal predominance. It need not show, it can still be predominantly axial or peribronchovascular. It can show subpleural sparing. Okay, main usually does not, but can show. Okay, so here the short is slightly different. Okay, so the short stands for S for sarcoidosis, H for hypersensitivity pneumonitis, O R for organizing pneumonia, and strictly speaking, organizing pneumonia would be usually a consolidation, and T would again be for tuberculosis. Okay, and I'm primarily talking about post-primary tuberculosis. We'll get to that in our discussion on imaging of pulmonary infections. So let's just take some representative examples and apply the algorithm. So what is your differential? So what we can see very clearly is there is a reticular opacity with some degree of consolidation. Okay, it is predominantly affecting the upper lobes. So in step 1, we say that there is a predominant apical involvement. So the differentials become our short DDX. Okay, so what is your short DDX? Yeah, so the short DDX is sarcoidosis, hypersensitivity pneumonitis, occupational lung disorders. O for occupational lung disorders excluding asbestosis, R for radiation pneumonitis, T for tuberculosis, D for double damage, that is pleuropulmonary fibroelastosis. Now there is a little bit of nuance here. Okay, there is definitely reticular opacities, and there is the hyla should be here, but they have migrated upwards because they are being pulled by my fibroblastic foci. UIP is definitely excluded, so it is short DDX as I've just discussed. So can I narrow it down further? Actually, yes, I can. Okay, so if you look very carefully, this is a branch of the left pulmonary artery, and you find subtle studding along these branches. Okay, so if you remember from our discussion on evaluation of pulmonary parenchymal opacities, pulmonary studding was very characteristic of the bronchovascular pattern and the perilymphatic pattern. It can only occur with those two patterns, and that happens and is very characteristic of sarcoidosis. Okay, so since that is present, you would find that this is either sarcoidosis or occupational lung disease. Okay, very unlikely to be anything else. Okay, so that's how you combine those two together. Now again, in this example, let's apply the algorithm. So one thing that is very obvious immediately is that this is a axial cut through the base of the lung. Why do I say it is the base of the lung? Because I can no longer see the trachea. Okay, so this is the base of the lung, the two lower lobes. And yes, there is a lot of ground glass opacity. There is some we'll go step by step. So step 1, there is definitely a basal predominance, although I have not shown you the apical images, but take my word for it. Okay, for now, because I wanted the images to be very clear. Okay, so we'll just go to step 2. Okay, so now in case of step 2, what we find is that there are some areas where there is subpleural sparing. Okay, now it's very subtle, that's why I wanted the image to be very large. Okay, there is subpleural sparing in some areas. Okay, here as well. Now subpleural sparing means it's not UIP. Okay, so again we are talking about our short, not the short DDX, it is now short. Okay, so short would be sarcoidosis, hypersensitivity pneumonitis, organizing pneumonia, and tuberculosis. Okay, and because this is predominantly GGO and there is just like super added reticular opacities are there in the background, I would prefer organizing pneumonia and NSIP over hypersensitivity pneumonitis. Strictly speaking, I would say NSIP more. Okay, organizing pneumonia would be more consolidations, but there is some degree of peribronchovascular thickening, and we've discussed previously that we say it is thickened in comparison to the normal the oblique fissures thickness, and in this obviously you can't see the oblique fissure because these are both by the lower lobes. Okay, so there is some thickness is what I'm trying to say, and that would favor a diagnosis of organizing pneumonia also. So that is why it is probably an organizing pneumonia or an NSIP more than hypersensitivity pneumonitis. So finally we have demonstrated that clinical images show reticular opacities, show a broad range, and they can be clubbed into 4 categories that have been formalized by the Fleischner Society. We've understood why histopath is required only in very specific scenarios. We've understood that there is one entity that can closely mimic UIP pattern ILD, and that is obviously our HP, hypersensitivity pneumonitis, but it has to jump through proverbial hoops to do so, and we've derived a generalizable diagnostic framework. So I hope that is clear, and in the next section in this subsection of an approach to chronic dyspnea, we'll be discussing non-fibrotic ILDs. Okay, and 2 of them I have alluded to already, that is your organizing pneumonia and LIP patterns, but you'll see I classify them a little bit differently from how it has been done in Harrison. from my own clinical experience and how I approach patients, and I find that much more intuitive and based on pathogenesis. I don't like the classification given in Harrison because it doesn't recapitulate the underlying pathogenesis very well. However, we'll go through both classifications and we'll try to reach a consensus, and I'll discuss how that would clinically be relevant. So thank you, and I'll see you in the next video.